This is central nervous system infections. Nothing could be more central to infectious disease. Well, the most important thing is how to answer those questions. Which of the following is the most likely diagnosis? Now, if you look at our three main infectious diseases of the central nervous system, such as a meningitis, encephalitis, and a brain abscess inside of me. Well, the first thing is, how do you answer the question, which of the following is the most likely diagnosis? Well, which of these gives you a fever? Well, they all give you a fever. Both a meningitis and encephalitis and an abscess all give you a fever. Which of them gives you seizures? Well, all three of them can give you seizures. Which of them gives you a fever and a headache and seizures? They all could. Now, if they want you to know the answer on step 2, they have to tell you something. So if they want you to know the answer, they have to tell you something. If they want you to know the answer, they have to let you know. So if they want you to answer the question, which of the following is the most likely diagnosis in this patient? And they want you to know it's meningitis, they'll have to tell you, A, it's a guy who's got a fever and a headache and a stiff necky, a neck stiffy, stiff neck and photophobia, stiff neck and photophobia. Well, if they want you to know the answer, they have to tell you something. And if they want you to know the answer, that this is meningitis, which of the following is the most likely diagnosis, they'll say a guy comes with fever, headache, stiff neck, photophobia, Koenig's and Brzezinski's sign. If they want you to know that the most likely diagnosis is encephalitis, they'll tell you a fever, a headache, and confusion. So which of the following is the most likely diagnosis? Fever, headache, confusion. Acute febrile confusion. If they want you to know that the person has an abscess, they'll say fever, headache, and focal neurological findings. If they want you to know the answer, they have to tell you something. Now, what if they give you 2 of them? What if they give you 3 of them? If they want you to know the answer, well, if they say confusion and stiff neck, then you can't tell. Could be either one. If they say focal and a stiff neck, could be either one. If they say focal and confusion, could be either one. If they say focal and confused and a stiff neck, could be any one of them. So if they tell you seizure, you can't tell. Fever and headache, then you can't tell. If they want you to know, they'll tell you fever, headache, stiff neck, or fever, headache, confusion, or fever, headache, and focal neurological findings. Now, the next step is, when you have a person who has a fever, a headache, and a stiff neck, and a photophobia, in whom do you have to do a CT scan before a lumbar puncture? Now, I know that many of you have only ever seen CT scans done before lumbar punctures, but you don't have to. You don't have to. When do you have to do a CT scan before the lumbar puncture? When do you have to do the CT scan before the lumbar puncture? And the answer is, you have to do the CT scan before the lumbar puncture when there is focal neurological damage, when someone has severe confusion. Well, how can I tell if you have focal neurological damage if you have severe confusion? How can I tell if you have focal neurological damage when I ask you, touch my finger, touch your nose, and you say, squeeze my hand. Can you feel this wisp of cotton? Move your finger. Now, neurological exam is almost all based on the ability to follow commands. Touch my finger, touch my nose. What if somebody's got severe confusion? You say, touch my finger, touch my nose, and they go, how can I tell if you're focal? How can I tell if you're focal if you can't follow commands? If you can't follow commands, I cannot do a neurological exam. Okay? Here, let's do walk. Let's do the Macarena for 30 full seconds. It's based on the ability to follow commands. How can I tell if you're focal? How can I tell if you have papilledema? Most of you have never seen papilledema in your life. How can I tell if you have papilledema if I try to look in your eyes and you go, you can't even see papilledema in a normal person. Look into my eyes. Look, 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 look into my eye. Do you see the papilledema? How can you tell? How can you tell? Here, touch the camera nose. Touch, 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 touch. Oh, see? You need to have a normal neurological exam in order to be able to follow commands to do the neuro exam. And another soft one is a seizure. Now, if you don't have focal findings, papilledema, confusion, if you don't have focal findings, papilledema, and confusion. If you don't have focal findings, papilledema, and confusion, if you don't have focal findings, papilledema, and confusion, you don't have to do the CT scan before the lumbar puncture. In which case, you do the lumbar puncture and the cerebrospinal fluid. Lumbar puncture and the cerebrospinal fluid. What is the single most accurate test on cerebrospinal fluid for the diagnosis of bacterial meningitis? Which of the following is the most accurate diagnostic test? And the answer is culture. Culture. But culture takes 3 days. You never have the results of culture. It's like saying, how do you know who the right girl is to get married to? Oh, the one that you won't get divorced from. But you don't know if you're going to get divorced until you get married. Oh, that's true. So how do we tell what the most likely diagnosis is when you don't have the culture for 3 days? Culture is the most accurate test, but we can't wait for the results of culture. What is the most accurate? Culture. If it's a bacterial organism, what's the most common bacterial organism to cause meningitis? What's the most common bacterial organism to cause meningitis? It is strep pneumonia, strep pneumonia, strep pneumonia. What's the most common adolescent? Neisseria, Neisseria, Neisseria. What's the most common? What's the most common? Okay, so the thing is, culture is the most accurate. Culture is the most accurate, but we can't wait for the results of culture. What's the single most sensitive test? And the answer is probably a protein. If you have a normal protein, protein is extremely sensitive. Sensitive means that a negative test rules it out. A negative tester rules it out. A negative tester rules it out. Sensitive means a negative tester rules it out. A very sensitive test, a protein level. If you have a normal protein, you don't have bacterial meningitis. Now, people who have bacterial meningitis can have a low glucose level. They can have a low glucose level, but a low glucose level does not have any actual sensitivity. In other words, a small number of people can have a low glucose level, but you can have bacterial meningitis without a normal glucose level and without a low glucose level. It's not good enough. It's one of those, yeah, bacterial meningitis sometimes causes a low glucose, sometimes, but it's not good enough. Chemistry is a very inexact way of making a diagnosis. Culture is the most accurate, but I can't wait for the results of culture. Protein is very sensitive, but if it's elevated, it's nonspecific. Which form of meningitis can elevate your protein? The answer is all of them, all of them, all of them, all of them, all of them. Which of them can elevate your protein? All of them, all of them, all of them, all of them. All of them, all of them, all of them, all of them could elevate your protein. Culture is the most accurate. Glucose is not sensitive nor specific. So that means your question of treat, don't treat is based on what finding now of treat versus don't treat. What finding now? The answer is cell count. How do you determine whether to treat or not treat now? And the answer is cell count. The cell count is what's going to tell us, gee, is it thousands of polys, thousands of neutrophils? Thousands of neutrophils means bacterial meningitis now. Now, it can't tell you whether it's adolescent with a rash, adolescent with a rash, adolescent with a rash, Neisseria. 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 Nah, it can't tell you most common strep pneumonia. It can't even tell you whether it's a bacterial meningitis in a neonate, group A, group B, beta-hemolytic strep, group B, beta-hemolytic strep, strep A galactiae. Can't tell you which bacteria. But thousands of neutrophils tells you it is bacteria. Thousands of neutrophils is enough to allow you to answer the question, the next best step in the management of this patient is treatment. Treatment. Ceftriaxone intravenously. Ceftriaxone, what's the dose? I'm not going to tell you. Ceftriaxone, what's the dose? I'm not going to tell you. Ceftriaxone, what's the dose? I'm not going to tell you. Oh, you don't know it, you're stupid. That's Dr. Stupid to you. And I happen to know the dose because I'm smart, see? I'm smart. But I'm not going to tell you even though I know. I'm not going to tell you the dose because I'm protecting your mind. You see, that's what people who are in a relationship do for each other. I withhold certain things. Oh, but you're not being honest with me. Oh, but you see, I could be honest with you, but it would hurt your mind. So I'm purposely withholding information from you that I think doesn't help you and that you don't need to know. Like dosing. Yeah, dosing. You see, dosing. Oh, but you're not being fully honest with me in the relationship. If you were fully honest, you would tell me everything. But why should I tell you something like dosing, which is not asked, hurts you, fills your mind with a bunch of crap you're going to worry about, and in the end doesn't help you? So is it dishonest of me to withhold something from you that doesn't help you, makes you crazy, or worries you? Well, I don't know. I don't think it's dishonest. I think it's considerate and loving for me to withhold from you things from your mind that will only hurt you and make you crazy, and that in the end you didn't really want to know. Like dosing. Don't learn the dosing. Okay? Ceftriaxone and vancomycin. You see, USMLE does not ask dosing. USMLE asks things like route of administration. Route of administration. So I think it's important to tell you how we're going to give it to you, but I don't think the dose is important. Intrathecal. Well, who gets intrathecal antibiotics directly into the spinal cord? Who gets intrathecal? And the answer is no one. Intrathecal. Intrathecal antibiotics, like television on honeymoon. Not necessary. Not necessary. It doesn't help. If your meninges are inflamed, it will pass. Anything will pass. Ceftriaxone and vancomycin. Okay? Oh, new thing, and steroids. Adding glucocorticoids. Now this is news since our last videotapes. And steroids. Steroids, that's something new that's developed over the last few years. Several years ago, we would have said it's only steroids for TB meningitis, but steroids are now indicated for bacterial meningitis as well. Steroids are now indicated for bacterial meningitis as well, which you tell if there's either thousands of polys or a positive gram stain. Thousands of polys or positive gram stain. Thousands of polys or positive gram stain, and you're going to add steroids for either thousands of polys or a positive gram stain. Steroids lower mortality when there's a positive gram stain or thousands of neutrophils. Steroids lower mortality for acute bacterial meningitis. Steroids lower mortality for acute bacterial meningitis. Steroids lower mortality for acute bacterial meningitis. Ceftriaxone, vancomycin, and add steroids for acute bacterial meningitis. Steroids lower mortality in pneumococcal and bacterial meningitis. And steroids are also indicated for tuberculosis meningitis. They're also indicated in TB meningitis. Thousands of neutrophils. Culture is the most accurate, but I can't wait for the results of culture. Gram stain can be done now, but the gram stain only picks up 60 to 70%. It's only 60 to 70% sensitive. What's the dose? I'm not going to tell you. What's the route? Never intrathecal. Intravenous is sufficient. Intravenous is sufficient. Now, the cell count can also show a couple of dozen to a couple of hundred of lymphocytes. A couple of dozen to a couple of hundred of lymphocytes. And a couple of dozen to a couple of hundred of lymphocytes can be several forms of meningitis. And those several forms of meningitis that it could be cryptococcal with a couple of dozen to a couple of hundred lymphocytes. It could be Lyme disease. It could be Rocky Mountain spotted fever. It could be TB meningitis. It could be viral meningitis. All of these have 50, 70, 80, 100, 100, 200, 300 lymphocytes. A couple of dozen to a couple of hundred lymphocytes. All these have a couple of dozen to a couple of hundred lymphocytes in the CSF. All of these will have a negative gram stain. All of these will not show up on bacterial cultures. All of these. Now, India Inc. is the most accurate, best initial test for Cryptococcus. India Inc. is like a gram stain. It's positive in about 50 to 60%. Which of the following is the most accurate diagnostic test for cryptococcal meningitis? Which of the following is the most accurate diagnostic test? And the answer is cryptococcal antigen. Cryptococcal antigen testing. Well, what in the case is going to tell you? Please get this answer to the question, cryptococcal antigen. You see, welcome to infectious diseases. And in infectious diseases, half of what we learn is basically not just the test, but what is going to be in the case that tells you to get that test. For instance, why should we get serology, IgGs and IgMs for Lyme? Serology, IgGs and IgMs in Western blot for Rocky Mountain. Why should we get a cryptococcal antigen, or a Lyme serology, a Rocky Mountain spotted fever serology, a TB smear and culture, a TB smear and culture. What is going to be different? What's unique? What is different? What's unique? Oh, fever? No, 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 no. They all give a fever. They all give a fever. Headache? No, 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 no. They all give a headache. Stiff neck? No, no, no. They all give me stiff neck. Photophobia? Bright light hurt. We belong in dark. They all give you fever, headache, stiff neck, and photophobia. So what is different? What's unique? What's going to tell you if the ink and the cryptococcal antigen? The answer is AIDS. AIDS. AIDS and low T cells. AIDS and low T cells. AIDS and low T cells. AIDS and low T cells tells me to get the cryptococcal antigen. AIDS and low T cells, less than 100. And that's what tells me to get the cryptococcal antigen and give the amphotericin. That's what tells me to give the cryptococcal antigen, give the amphotericin. What is different? What's unique? When I treat the cryptococcal antigen with amphotericin, does the antigen level change in response to therapy? Does the antigen level change in response to therapy? What is it that's going to tell you that? Well, it's going to be AIDS and low T cells. Low means under 100. Does the cryptococcal antigen change in response to therapy? The answer is yes. Antigens change, but antibodies don't. If you give amphotericin, the cryptococcal antigen change does go down in response to therapy. So the antigen does change, because antigens change and antibodies don't. Now when I treat HIV with antiretrovirals, does the HIV antibody go away? No, because antigens change and antibodies don't. Antigens change. Now, PCR is like an antigen. A PCR is like an antigen because it's direct organism. It's direct measurement of the organism, of the fungus or the virus. So when I treat hepatitis B, does the hepatitis B E antigen change? When I give interferon or lamivudine or adefovir or entecavir, a different interferon or lamivudine, does the hepatitis B E antigen change? And the answer is yes, because antigens change and antibodies don't. When I treat the hepatitis C with interferon ribavirin, does the antibody change? The answer is no, because antigens change and antibodies don't. Therefore, if I treat hepatitis B, the E antigen goes away. If I treat cryptococcal meningitis, the cryptococcal antigen goes away. But if I treat hepatitis C, the hep C antibody does not go away, because antigens change and antibodies don't. Oh. Cryptococcus. AIDS, low T cells, tells me get the India ink. India ink, 60 to 70% sensitivity. Cryptococcal antigen, 95% sensitivity. Amphotericin is first, followed by fluconazole. How long does the fluconazole have to stay on board? And the answer is lifelong. It stays on board, except if the T cells go up. If the T cells go up, the fluconazole can stop. The T cells go up, the fluconazole can stop. The fluconazole stays on lifelong unless the T cells are corrected. What is going to tell me Lyme serology? What's going to tell me to get a Rocky Mountain spotted fever serology? Doxycycline is still for Rocky Mountain. Doxycycline for Rocky Mountain. Ceftriaxone, intravenous ceftriaxone for CNS Lyme. Well, what's going to tell me to get a serology for Lyme disease or a serology for Rocky Mountain spotted fever? What is different? What's unique? Not a fever, not a stiff neck, not a photophobia. What's different? Well, the problem is that only 20% of people who have Lyme disease remember the tick. That Lyme tick is so small that only 20% of people remember. You ask people, have you had unprotected contact with an anonymous tick? And most people say, oh no, it was so small, I don't even remember. It is like a little pinprick. It's like the size of the head of a pencil. Most people don't remember. So you can't say, I'm going to answer Lyme disease because I'm going to be looking for a chick with a tick, because most of the time it's not going to be there. Now, the tick will be there about 60% of the time in Rocky Mountain spotted fever because bigger ticks stand out in your mind. Now, since you can't rely on the tick exposure history, we rely on a euphemism for tick exposure history, which is camping and hiking. Do you remember the tick? But no, I remember camping and hiking, hiking and camping, camping and hiking, hiking and camping, camping and hiking, hiking and camping. Munch, Edvard Munch. So therefore, we remember that we went camping and hiking. So on step 2 of USMLE, everybody who goes camping and hiking dies because they either get Lyme, Rocky Mountain, or giardiasis based on what you do on your camping trip. So don't bother learning geography. Geography is always very difficult. Look, these tapes are used all over the world, 160 sites in 20 countries. So if I tell someone like me, we're recording in New York City here, right in Times Square. Here I am, right in the heart of New York City, live from New York. It's a videotape with Conrad Fisher. Yes, it's true. So here in New York, if I tell you that Lyme occurs in New York and New Jersey and Connecticut and Massachusetts, that has a lot of meaning. But what if I go down south, go down there, North Carolina, South Carolina, Georgia, and I say, up in New York, New Jersey, Connecticut, Massachusetts, dug down to Texas, you know what they say over there? They go, where are those places? Isn't it like one place? You guys even in the United States? We thought you were part of the European Union by now. So geography is easy only if it's your geography. So if you know that Lyme is in New York and New Jersey and Connecticut and Massachusetts, that's good. But the problem is most people can't remember their own geography. Look, I'm a real New Yorker. It goes like this. 7th Avenue, 8th Avenue, 9th Avenue, Philadelphia, Chicago, Los Angeles. Who can even remember? Now, Rocky Mountain spotted fever. If you know where North Carolina, South Carolina, Kentucky, Virginia, Alabama, if you know where those places are, then you know that's great. But geography is only easy if it's your geography. If it's not your geography, it always tends to be a mystery. So therefore, we have a way here for Step 2 students who are seeing these tapes everywhere from Paris to Karachi, from Johannesburg to Jerusalem, and that is saying, you know what? If you don't know where those places are in your geography, you look for a camper and a hiker who's exposed to a tick who has a particular rash. The rash in Lyme looks like a target. Red on the outside, pale on the inside, red on the outside, pale on the inside. And what's different about the rash for Rocky Mountain? The rash for Rocky Mountain is unique because the rash for Rocky Mountain moves in centrally. Moves in centrally. Starts out here and moves in here, starts out here and moves in here, starts out here and moves in here, starts out here and moves in here. Starts out peripherally and moves in centrally, starts out peripherally and touches my body. That's Rocky Mountain spotted fever. Centrally moving. Camper, hiker, tick, central moving rash. Camper, hiker, probably don't remember the tick. Target lesions. Now, 7th cranial nerve palsy and joint manifestations will help. 7th cranial nerve palsy and joint manifestations will help as well. Now, TB meningitis. Well, there's two things about it. We should look for TB that's in the lungs. That will help us. The other thing is, what is different about TB meningitis on cerebrospinal fluid characteristics? What's different about TB meningitis on cerebrospinal fluid characteristics to help you make the diagnosis? What is different and what's unique? The thing that is different and unique about TB meningitis, different from all the other forms of tuberculosis, forms of meningitis, is it is the form of meningitis that is most likely to have a high protein level. It is the form of the meningitis most likely to have the single highest protein level. TB meningitis can be in the lung TB. However, 15% of TB meningitis does not have lung disease. It has the single highest protein level. What's different about TB meningitis from TB in the lungs? TB in the lungs gets treated with INH, rifampin, PZA, and ethambutol. INH, rifampin, PZA, and ethambutol. INH, rifampin, PZA, and ethambutol. That's for the same, for the lung and for the CNS, for the lung and the CNS. So what's different about TB meningitis is that TB meningitis, you extend the length of therapy and you add steroids. You extend the length of therapy from TB in the lungs and you add steroids. There are two forms of tuberculosis that should get treated with steroids. Two forms of TB that could get steroids are TB meningitis and tuberculosis involving the pericardium. TB pericarditis. TB pericarditis. Now, what is different and unique for viral? There is nothing particularly different and unique for viral, and there is no particular therapy or test for viral meningitis. You ready? What we've done here is say this. The first thing that you should do in evaluating fever, headache, and a stiff neck is to say, okay, does this person need a CT? They need a CT if there's focal findings, papilledema, severe confusion, which makes my neurological exam inaccurate, or a seizure. Okay, I did a lumbar puncture. What's the most accurate test in the lumbar puncture? Culture. I can't wait for the results of culture to answer treat, don't treat. What do I base the decision of treat, don't treat on? Gram stain misses 40%. Protein and glucose are too non-specific and too insensitive. I base my decision treat, don't treat on cell count. Thousands of polys, ceftriaxone, vancomycin, steroids. Dozens to hundreds of lymphocytes. That could be Cryptococcus, Lyme, dry Rocky Mountain, TB, viral. How do I answer the question? Diagnostic test. In the ink and antigen, I see AIDS and low T cells. How do I answer Lyme or Rocky Mountain serology? I see a camper and a hiker with a target rash, red on the outside, pale on the inside, red on the outside, pale on the inside, or Rocky Mountain spotted fever with a person with a centrally moving rash. Now, if someone has such severe meningitis that they need that CT, we have to start treating them prior to the results of the CT and the LP. If there's a delay to the lumbar puncture, we have to start treating them prior to the start of getting the LP. So if there's a delay to giving the antibiotics, let's say it's like this. You have a person who's got, let's say, a 48-year-old guy comes to the emergency department with a fever and a headache and a stiff neck and a photophobia and a Kurdigs and a Brzezinski's, and he's got also a weak arm and leg. A weak arm and a weak leg. Fever, headache, stiff neck, photophobia, Kurdigs and Brzezinski's, and he's got a weak arm and a leg. He does need to get a CT scan. He does need a CT scan. He needs a CT scan, and a CT scan is good. CT scan is good. However, even though a CT scan is good, giving ceftriaxone and vancomycin as antibiotics is gooder. Even though a CT scan is good, if you have any time there is a delay to getting the lumbar puncture, anytime there is a delay to getting the lumbar puncture, you must start therapy to keep the person's brain from frying. Anytime there is a delay to starting the antibiotics and starting the lumbar puncture, you must give the antibiotics. In other words, you can't say, hey, just get a CT scan, and then you listen to his brain fry. If there is a delay, and you ready? Doing a CT scan is equal to saying there is a delay. When do I do a CT? Focal findings, papilledema, severe confusion seizures. If there is a CT which equals a delay, give the antibiotics, then get the CT, then do the lumbar puncture. Give the antibiotics, then get the CT, then do the lumbar puncture. That's what you do. Delay. Now, ready? Next one is this. We have a 17-year-old guy who has a seizure while kissing his girlfriend. And he comes in, he's got a fever and a headache and a headache and a fever and a fever and a headache and a headache and a fever. He's got a fever and a headache and a stiff neck, and he's got a rash. He's an adolescent with a rash. Adolescent with a rash. He's got an adolescent with the rash, and he's got thousands of polys. He's got thousands of polys, thousands of polys. What's the next best step? Well, ceftriaxone vancomycin. Well, the question is, what is different about this case from the others? First of all, the organism. An adolescent with rash most likely has the organism called Neisseria meningitidis. Neisseria. First, the diagnostic question. Adolescent rash, Neisseria. Second question, what is done differently for this guy compared to the other types of meningitis? And the answer is, he gets isolated, and the other thing is, he gets either ciprofloxacin or rifampin. Ciprofloxacin or rifampin to the close contacts. Ciprofloxacin or rifampin to the close contacts. Ciprofloxacin or rifampin to the close contacts. Isolate, rifampin, cipro to the close contacts. Now here's the question. What does it mean to have a close contact? What does a close contact mean? Well, close means salivary close. I can't give you Neisseria from over there. Come closer, come to the TV screen. Come on now. Reach forward, reach your hands around the TV screen. Okay, huggy, huggy, huggy. Yes, that kind of closeness. You actually have to have salivary contact to get Neisseria. You ready? Routine school and work contacts do not get prophylaxis. Routine work and school contacts do not get prophylaxis. Routine. In other words, a teacher has Neisseria meningitis. You do not give the students in the classroom antibiotics. Routine school and work contacts do not get prophylaxis. Household contacts. Household contacts. Household contacts do. Salivary contacts. How about this? The nurse comes to you and wants cipro or rifampin prophylaxis. What do you tell her? You say, unless you're kissing the patient or you got a face full of oral secretions, salivary secretions, no routine prophylaxis. You isolate. You prophylax the close contacts. The guy has recurrences. He's got a recurrent episode of Neisseria meningitis. What is the test? What do you test him for? So what's different? Adolescent rash, Neisseria. Isolate, prophylax the close contacts. What do we mean by close contact? Salivary contact. Next, he has a recurrent episode of Neisseria. What do you do for him? The answer is terminal complement deficiency. Terminal complement deficiency. Terminal complement deficiency. Now, let's change this case here. And instead of this being a 48-year-old guy who's got a fever and a headache and a stiff neck, let's make it an elderly neonate. Elderly neonate who's HIV positive, who's on steroids for leukemia and lymphoma. Steroids for leukemia, lymphoma, he's got a fever, headache, stiff neck, and photophobia, and he's got a history of leukemia and lymphoma. He's got a history of leukemia and lymphoma. Leukemia, lymphoma, HIV, steroid use, elderly neonates, alcoholic with meningitis, alcoholic with meningitis, alcoholic with meningitis, and he's got 1,500 polys. What will you do differently in the management of this case? What's the next best step in the care of this patient? What will you do now? Elderly, HIV, steroids, leukemia, lymphoma, bone marrow transplant with thousands of neutrophils. What you do differently is that you add ampicillin. You add ampicillin to the usual regimen of antibiotics. You add ampicillin to ceftriaxone, vancomycin, and steroids. You add ampicillin because this person might have what organism? What organism? What organism? What organism? What organism is associated with HIV, steroid use, leukemia, lymphoma? What organism? And the answer is Listeria monocytogenes. And Listeria monocytogenes is intrinsically resistant to all forms of cephalosporins. You need to get ampicillin. It's resistant to all forms of cephalosporins. You need to give ampicillin. Seizures while kissing, fever, headache, stiff neck, positive rash, polys. Isolate ciprofloxacin for the close contacts. What do we mean by close contacts? We do not mean routine school and work contacts. We do not mean routine school and work contacts. Routine school and work contacts do not get Neisseria prophylaxis. Have to be salivary close. The other thing is, who should get vaccinated for Neisseria? Well, it's been added to the routine age 11 visit, but the other thing is college students who are in dormitories, crowding, Neisseria, barracks, military recruits who live in barracks, crowding, people who have no spleen, people who have steroid use, people who are immunocompromised, no spleen, steroid use, or in areas of crowding such as the military or in dormitories. It's also been added to the routine age 11 visit. If we see elderly, neonates, HIV, steroid using, that means a risk factor for listeria, and listeria is resistant to all forms of cephalosporins. Listeria is resistant to all cephalosporins. Well, that's the meningitis story. The encephalitis story is much easier. The encephalitis story is much easier because acute fever and confusion. Acute febrile confusion, somewhere around a couple of days to a couple of weeks. Acute febrile confusion. And acute febrile confusion is much easier because acute fever and confusion means basically herpes. Acute fever and confusion means basically herpes. Herpes encephalitis. Herpes encephalitis. Now you see confusion and a fever. So that means we have to do a CT, which is going to be negative the majority of the time. There has been, and will probably continue to be, only one diagnostic test on herpes encephalitis. That is the question called, can you recognize the diagnosis, and can you answer what is the most accurate diagnostic test? So what is the most accurate diagnostic test for herpes encephalitis? The most accurate diagnostic test for herpes encephalitis is PCR. Polymerase chain reaction. PCR is better than a brain biopsy. Better than a brain biopsy. Able to leave tall frontal lobes in a single bounds. Look, it's a burr hole. Look, it's ice fishing inside your brain. Look, it's going in with tweezers and plucking out a little spot of my brain. I need a brain biopsy like I need a hole in my head. PCR is the single most accurate test. PCR is the single most accurate test, polymerase chain reaction. It was acyclovir, it is acyclovir, it's going to stay acyclovir. Why not famciclovir or valacyclovir? Because famciclovir and valacyclovir in general have the same efficacy. The answer is famciclovir and valacyclovir are not intravenous. Famciclovir and valacyclovir are not intravenous. Now, our final story, remember, is going to be an abscess. Someone who's got a fever and a headache. Oh, I've seen that before. A fever and a headache, and a headache and a fever, and a fever and a headache and a headache and a fever. Fever and a headache and focal neurological findings. Gets a CT scan with contrast that shows a ring or contrast enhancing lesions. A ring or contrast enhancing lesions. A ring or contrast enhancing lesions. If this person is HIV positive, then we will treat for toxoplasmosis for 2 weeks with pyrimethamine and sulfadiazine. If this person is HIV positive, they're going to get treated for toxoplasmosis and repeat the scan in 2 weeks. If this person is HIV positive, 90% of the time, mass lesions in the brain in HIV that are ring enhancing are toxo or lymphoma, 90% of the time. So if you treat and you repeat the CT in 10 to 14 days, if the lesion is smaller, it means it was toxoplasmosis. What else besides toxoplasmosis will respond to pyrimethamine and sulfadiazine? What else besides toxo will respond to pyrimethamine and sulfadiazine? The answer is nothing. So if you have a response to pyrimethamine and sulfadiazine, and you say, well, you know what, it's smaller, you're just going to continue. And you can continue to do the same thing. If you say that that lesion is the same, that means that you should biopsy. If that lesion is the same, it means that you should biopsy. Pyrimethamine, sulfadiazine, pyrimethamine, sulfadiazine, treat and repeat. Remember, in AIDS, 90% of the time, that's going to be either toxo or lymphoma. So when you see a ring-enhancing mass lesion in AIDS, it's toxo or lymphoma, treat and repeat. Now, if the person is HIV negative, that means you should go straight to a biopsy. And the reason is that you can't tell what it is. There are two groups of things that cause ring or contrast-enhancing mass lesions. One is cancers and the other is infection. In AIDS, that cancer or infection is toxo or lymphoma 90% of the time. But in HIV-negative people, it can be astrocytomas or glioblastomas. It can be staphylococcus or streptococcus or anaerobes or gram-negatives. You can't tell. Biopsy. Biopsy. Ring-enhancing lesion in AIDS, pyrimethamine and sulfadiazine. Penicillin allergic, clindamycin and pyrimethamine. For 2 weeks, treat and repeat. If the lesion is smaller, you take that as evidence of effective diagnosis. If the lesion is the same, you biopsy it. Fever and headache, stiff neck, meningitis. Fever and headache and confusion, encephalitis. Fever and headache and focal findings, brain abscess. If you have acute febrile confusion, CT, LP, PCR is better than biopsy, give acyclovir. If you have a ring-enhancing mass lesion and you're HIV negative, you can't tell if it's a glioblastoma or Staph aureus. CNS infections, acute febrile confusion, encephalitis. Let's look at some of the pictures here. Well, we have a picture here of a person who's got, well, it's not quite a person, but he certainly is a brain. You see this stuff here? The white areas? The white areas, you see this word meningitis? Do you know what the word meninges means? It means covering. Covering. This is just saying, well, there's an inflammation of the covering. That's pus material. That's not supposed to be as white there. Well, it says that in neonates, they get group A beta hemolytic strep. Now, what's the other name for group B beta hemolytic strep? Group A is Pyogenes. Group B is strep A galactiae. Now, strep pneumonia is the most common everywhere else because in children, the children have been getting vaccinated against Haemophilus. So that's why 95% of Haemophilus brain infections are gone. Adolescents get Neisseria, and remember that Neisseria causes a rash. Anytime you cut the skin, you get Staph aureus. Anytime you cut the skin, you get Staph aureus. Cryptococcus is AIDS and low T cells. Well, just saying, what's it look like with a stiff neck there? Nuchal rigidity. Now, you notice I didn't make a big thing about which is Kernig's and which is Brzezinski's because it doesn't matter. Stiff neck. Well, this is the purpuric or the Neisseria meningococcal rash. Meningococcus, whether it's Neisseria meningitis or gonococcus, give a rash. It causes a localized vasculitis. A localized vasculitis. These are gram-negative diplococci. Did you know that there's really only one gram-negative diplococcus that causes meningitis? The only one gram-negative diplococcus that causes meningitis is really only Neisseria. Only Neisseria. These are gram-positive diplococci. 2 guys, 1, 2, 1, 2, 1, 2, 1, 2, 1, 2, 1, 2, 1, 2. This is pneumonia, which is a gram-positive diplococcus. Remember, Listeria is a gram-positive. Listeria is a gram-positive rod, not a bacillus. Well, you see this stuff around here that looks like a ring? What would you call it if you had ring around a lesion when something it looks like a ring? When you have a ring-enhancing mass lesion, it's called a ring-enhancing mass lesion. If this person is HIV positive, they get pyrimethamine and sulfadiazine. If this person is HIV negative, they get a brain biopsy. More brain abscesses without contrast. More brain abscesses without contrast. See, there's a hole in the brain. That's an abscess. Well, that brings a conclusion to our central nervous system infections. I will see you in the next section.